Well, good evening and welcome to Question Lab. I am Jeff Downing. I'm your host tonight. I want to welcome each and every one of you to tonight's session where we are going to be tackling questions connected to renal physiology. So should be a good session. We've got some good questions lined up for you. So settle in. I want to first off introduce my co-host tonight, Dr. Paris Vicaria. Paris, would you like to say hello to the crowd?
Yes, thank you, Jeff. Hey guys, my name is Paris. I'm a dermatology resident in Dallas, Texas. I originally graduated from pharmacy school and then went back to finish medical school. I also am an RX coach with USMLE-Rx, meaning I work one-on-one with students such as yourselves to help prepare you guys for the USMLE Step 1 and Step 2 CK as well. And I'm happy to help lead tonight's session.
So let's go ahead and get started. And we'll go with question 1 here. And again, if you're a first timer and you see the question as we present it here, you'll say, where are the answer choices? Well, again, this is by design. So a couple of things that we suggest that you do. First, we say cover up the answer choices. And the reason we say that is because we don't want you to be distracted. Sometimes you'll lock onto a word or a term or maybe a medication that you've never heard of, or a hormone you've forgotten about, and it can throw you. So really, we want you to stay focused, and we ask you cover up the answer choices, and then we tell you that you should read the lead in first. So read that question, which is, in this case, which of the following is the most likely diagnosis? So we ask you to read the lead in first so that you know what kind of information you should be keying in on as you go to the vignette. Okay, so again, cover up those answer choices, read that lead in, and then go to the vignette. So that's what we're going to do. And again, the lead in, which of the following is the most likely diagnosis? And now let's go to the vignette. A 66-year-old man comes to the clinic for a routine follow-up. He has a history of type 2 diabetes mellitus, hypertension, and chronic kidney disease with a baseline serum creatinine of 2.2. He takes metformin, enalapril, and diltiazem. Physical examination is normal, and he feels well. Laboratory studies show serum sodium of 140, potassium of 5.5, chloride of 110, bicarbonate of 18, creatinine 2.2, blood pH of 7.3, and urine pH of 5.2. So again, the question, which of the following is the most likely diagnosis? So think about how many steps you think it would take to answer this question. You can put your responses in the question box. And now I'm going to hand it over to Paris to help break this down. Paris?
Thank you, Jeff. So what we're going to do is we're going to start off by showing you what we think are the important clues in this vignette and the lead-in. So, starting off, whenever they give you a question, usually they provide you with demographics, and that's the most important first thing to make note of. So in this case, we have an elderly gentleman, okay? A lot of times then they'll tell you, where are they coming in and what are they coming in for? So why are they coming to the hospital? Why are they coming to their physician, the ER? So you want to make note of those signs and symptoms that they present with. Okay, and a lot of times they'll also tell you how long that issue's been going on for. Now in this case, it's actually just routine follow-up. Okay, no specific issue bringing this patient in. Okay, so in that case, we know this is kind of like a chronic checkup visit. Okay, so you want to make note of their chronic conditions, You want to check their medications. You want to check their certain blood work to see what's going on, both in real life and then also in this question, okay? So in this case, we think it's important that you make note of all their comorbidities. You make note of their medications because, as you can see, there is a diagnosis here, and there could be something wrong with one of those, including the lab values, okay? And if you look at the lab values, you may be wondering, some of those look a little bit off, okay? So then if we get down to the lead-in, this is asking us, what is the most likely diagnosis? So this is likely just a one-step question. We just need to come up with the diagnosis, but we're going to have to put our detective hats on and figure out exactly what's going on, okay? So let's take a look then at the answer choices, okay? And if we take a look at the answer choices, what we see are 5 answer choices. And what we recommend when you go through these answer choices is that you start at the bottom and that you work your way up to the top. So start with answer choice E and work your way up to A. And the reason we recommend this is because a lot of times we'll see students who, they'll start at the top, they'll see something they like, and they'll select it without having gone through all of them. And sometimes they'll get that question wrong as a result. So we recommend doing it this way so you don't make that mistake and you don't bias yourself. So we're going to go ahead and do that now. Answer choice E, type 4 renal tubular acidosis. Answer choice D, type 2 renal tubular acidosis. C, type 1 renal tubular acidosis. B, hyperaldosteronism. And A, acute kidney injury. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the correct answer here, the most likely diagnosis, and we'll talk about it in just a few seconds.
Excellent. Thank you, Paris. So the poll has been launched. Go ahead and make your selection. Got in one of these questions where you've got a lot of different lab values to sift and sort, but kind of maybe a more traditional one-step question. So let us know what you think is the most likely diagnosis. Looks like about half of you have registered your opinion. We'll give you a few more seconds. Make sure that you answer every question. Don't leave any questions unanswered on test day. Okay, let's see. Over 2/3 of you have voted, so I'm going to give you just a couple more seconds, and I'm going to close the poll. Some interesting results here. So we're going to close it, and I'll share the results. And not surprisingly, most of you kind of keyed in on the renal tubular acidosis, with most of you thinking it was E, but a good percentage of you thought that it was type 2 and type 1 following right on its heels. Okay, so with that, we're going to hide those results and present you with the answer, and the answer is, it is indeed E, type 4 renal tubular acidosis. Paris, why is E the right choice here?
Yeah, thank you, Jeff. Yep, definitely one of those tough RTA questions. So I know one of everyone's favorite renal topics. So let's go ahead, let's take a look. Let's make sure that we understand why this is type 4, okay? So one of the main things with your three main types of RTA is to know exactly where the issue is happening in the nephron, okay? That's one of the most important things, because from there, if you know the cells in that area, if you know the types of transporters, then you can figure out what's going to happen to the potassium, what's going to happen to sodium and bicarb and things like that, okay? Now, as we can see here, type 4 RTA is the one with an elevated potassium, and that potassium is a little bit elevated, 5.5. So automatically, maybe leaning towards type 4 RTA, okay? So if we take a look at this question, we see that this patient has a few medical conditions, okay? We also see that they have a few comorbidities. Okay. If you were to calculate their anion gap, okay, this patient has this patient has a low blood pH, 7.3. So we know this patient is acidotic. Okay. So this patient has an acidosis with a normal anion gap metabolic acidosis. So pretty close, but I think it's about 12. So with your normal anion gap metabolic acidosis, one of the things you want to consider is RTA. Okay. This patient also has hyperkalemia, so that would push me more towards type 4 RTA. Okay. Now this patient is on enalapril. They are on an ACE inhibitor. Okay, so we want to keep that in mind. Okay, so let's take a look at the next slide. We actually have a few slides we're going to go over briefly. So there's a really nice table and diagram in first aid that goes over your three main types of RTA. It shows you exactly what's happening at a cellular level so that you can understand mechanistically how this defect is happening, how you're developing acidosis, and also in the setting of RTA type 4, why you're getting hyperkalemia. So if we take a look at the next slide, we've kind of focused on specifically just RTA type 4, okay? And you can see here, it kind of will walk you through what is happening with RTA type 4. So in RTA type 4, it's almost like you have low aldosterone, so hypoaldosteronism or resistance to aldosterone. And that causes downstream, that causes a decrease in secretion of ammonium. Okay, it leads to elevated potassium in the blood or hyperkalemia. Okay, and you can see that diagram there. So this is RTA4. And on the next slide, even further, first aid goes into even more in-depth explanations on the differences and how to differentiate them from other lab values. Okay. So the urine pH would potentially be high in type 2 and is definitely high in type 1. And you can see there again the serum potassium is only elevated in type 4 RTA. It's also important to know the various causes. Okay, and in this case you can see our patient has a reason for having low aldosterone production. They are on an ACE inhibitor. So you want to know those certain causes that can either cause aldosterone production to lower or aldosterone resistance to develop. Those would be the two main umbrella terms for what is causing RTA type 4. Okay, so ACE inhibitors, ARBs, NSAIDs, potassium-sparing diuretics as well. So basically low aldosterone effects. And that would be type 4, so that's why you get hyperkalemia. So if we go back to our question and our answer choices, you can see there that type 4 RTA is the best one. We have a acidosis, 7.3 blood pH. It's likely metabolic because of that low bicarbonate. Okay, normal anion gap. RTA is definitely a good thing to think about. Okay, especially if they're giving you a urine pH and you see potassium slightly elevated. Now the other answer choices, type 2 RTA, that has hypokalemia, so we know that's not correct. Type 1 RTA also has hypokalemia, so we know that's incorrect. Hyperaldosteronism with answer choice B, that would actually lead to metabolic alkalosis, the opposite of what this patient has, would also have hypokalemia. And an AKI or acute kidney injury, that would be like an acute rise in creatinine from baseline. And we know that this patient's creatinine is not elevated from baseline. They told us their baseline was 2.2 and their creatinine today is 2.2, so they actually do not have an acute kidney injury. Okay. So answer choice E here would be the best answer. So hopefully this quick little summary of the three main types of RTA was helpful. And great job with this question.
Yeah, that's a great review. This is definitely high yield, and it's important for you to know your lab values, right? So good job for those of you got that one right, and for those of you who didn't, that's okay. You learned quite a bit through that dissection. Okay, let's go to question number 2. and go through. And again, we put this in the chat, but Paris was going over some of these these tables that are in first aid that are on page 617 of the 2021 edition. Okay, let's take a look at question number 2. And again, we're going to start with the lead in. Which of the following is the most likely consequence of this treatment? Think about that as we read the vignette. A 74-year-old man is brought to the emergency department 1 hour after his wife witnessed an episode of generalized tonic-clonic shaking with loss of consciousness. This lasted for about 2 to 3 minutes, and it took him about 30 minutes to recognize his wife. He also has a 2-day history of confusion, weakness, and paresthesias. His blood pressure is 105/80, falling to 90/70 when sitting up. Physical examination reveals he is disoriented with slurred speech. He cannot eat or drink fluids without gagging or spitting. Laboratory studies show a serum sodium level of 160, blood urea nitrogen of 45, and creatinine of 1.2. Intravenous fluid treatment leads to a serum sodium concentration of 141 2 hours later. So again, the question, which of the following is the most likely consequence of this treatment? And again, I'll ask you to think about how many steps it would take you to reach your answer. You could put that into the question box as I pass it over to Paris to show you the choices. Paris?
Thank you, Jeff. So once again, we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in, okay? So you can see here right off the bat, this is a little bit of a longer question, okay? So you want to make sure that you're going through and you don't want to miss any clues, whether it's in the very beginning or the very end, okay? So a lot of times what we see with these longer question stems that we'll often forget an important clue that we noted right off the bat, you know, because it ends up being so long from when you get to that lead-in again. So you want to make sure you're making note this is a long question stem. I don't want to miss any clues, whether they're right off the bat or later on. So for some reason, the demographics here weren't highlighted, but you would also want to highlight that. So 74-year-old man would also want to highlight that, okay? As we said, this is actually a good example of a presentation where there's a lot right in that first sentence. So this patient came to the ER, okay? And why did they come to the ER? Well, they had generalized tonic-clonic shaking. And a lot of times after that, you want to know whether they lost consciousness or not. And this patient, they said, did. So there was a loss of consciousness. They also give you a little bit of time frame. They came to the ER 1 hour after this happened, okay? Now, as you guys know, whenever you have these shaking or, you know, generalized tonic-clonic type things, you want to know about time. You want to know how long did it last and how long did it take to lose consciousness. It took him 30 minutes to recognize his wife after that episode, okay? So that's also important. We'll talk about that. They then tell us about what had been going up leading up to that event, 2-day history of some other things. So that's important, right? What was happening leading up to that event? You definitely want to make note of that, okay? They then give us some information about vital signs, physical exam finds. They say that he can't eat or drink without gagging or spitting, okay? And then they give us some important lab studies, okay? So you definitely want to make note of that. But then it doesn't end. They give us one additional thing to think about. They're saying that he was given IV fluid, and then that changed his sodium there. So they actually added an extra step there as well. So you don't want to miss that. You don't want to miss everything that's happened up until this point. So then they're asking the most likely consequence of this treatment. Okay, so I think we've got to figure out probably a couple things. I think you could look at this one way. You could say, okay, what's the consequence of the treatment, the IV fluid treatment they give him? Maybe a one-step question. But I think probably what we need to do is we need to figure out exactly what's going on. So that to me is step number one, putting all these clues together. Two, at that point, after that, then we talk about treatment, and then we talk about a consequence of that treatment. So I would actually like to say this is more a two-step than a one-step, okay? So let's go ahead, let's take a look at those answer choices. Once again, we see 5 answer choices here. What we're going to do is we're going to go through those answer choices again, one by one, starting at the bottom and working our way up to the top. Answer choice E, RBC lysis. D, diabetes insipidus. C, demyelination of the pons. B, dehydration. And A, cerebral edema. So once again, we're going to open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Okay, very good. Thank you, Paris. So the poll is launched. Go ahead and cast your vote. What do you think is the most likely consequence of this treatment? Obviously, there's a lot to parse from this particular vignette, and that is quite comparable to what you're actually going to see on test day. You're going to be often bombarded with a lot of information, and you need to figure out what's important, what is extraneous, and and what's actually happening to the patient. So this is a good question for everybody. Well, it looks like almost 3/4 of you have answered. So I'm going to go ahead and close the poll. And let's share the results. So very interesting. We've got a pretty clear leader in terms of the answers, the demyelination of the pons. Almost half of you answered C, with about 1/4 of you voting for cerebral edema. So with that, we're going to go ahead. We'll hide those results and let us see what the answer is. And the answer is cerebral edema. So those of you who sifted and sorted and got to answer A, congratulations. Looks like a lot of you, there's a reason why you were snagged by answer C. So we're going to turn it over to Paris to help break this one down. Paris?
Yes, thank you, Jeff. Yes, definitely a tough question, and a common thing we see with this topic. Okay, so let's take a look at this vignette again. Okay, so this patient, has a few things. They're orthostatic, right? That blood pressure drops when they go from a sitting to a standing position. Okay, so probably a little volume depleted. Okay. Now, this patient we know has hypernatremia and pretty high, 160. So hypernatremia, okay? So what that does is that hypernatremia causes hyperosmolarity. So it kind of will draw water out of cells into the blood to kind of balance out that osmolality, okay? So water will leave your cells to go and kind of regulate that osmolality, okay? So water will leave some of the cells, including the brain tissue, okay? It'll leave that and go into the blood. And because of that, that is why you can get neurologic deficits and signs and symptoms with hypernatremia, okay? This patient has a few signs and neurologic issues, generalized tonic-clonic shaking, a post-ictal state, so they're kind of confused for after that episode. That's what that not being able to recognize the wife is talking about, a post-ictal state. Okay. Also confusion, weakness, paresthesias. So a few neurologic issues happening because water is leaving the brain tissue to go into the blood because of the high sodium. Okay. Now, the patient was then started on IV fluid treatment, which is appropriate. Okay. you definitely want to help bring that sodium back down, okay? Also because their blood pressure might be a little low. However, you don't want to correct the sodium too fast. You do not want to correct it by more than 12 milliequivalents in a 24-hour time frame. And that number, that exact number can vary anywhere from 10 to 12, but mainly that's a good range. Now this you can see changed almost 20 just 2 hours later. You do not want to correct it again more than 12 milliequivalents in a 24-hour time span, let alone 20 in a 2-hour time span. That is way too fast. That is a rapid correction, okay? Now what happens if you do that, if you rapidly correct that sodium, what happens is you run the risk of cerebral edema. If you rapidly decrease that serum osmolality again, well, water is going to rush back into the tissues. It's going to rush back into the brain, and it can cause cerebral edema. That's why you'd want to do it very slowly. You want the fluids to slowly get back into their normal fluid balances. You don't want it to shift back into the brain very quickly. So if we take a look at the next slide, there's a table in first aid, and this is what happens. If you see there at the bottom in that table, correcting serum sodium too fast. If you correct from high to low, your brains will blow. You can get cerebral edema, which can lead to herniation, and that can lead to death as well. If you correct hyponatremia too fast, you get the opposite. Water rapidly leaves the tissue, and you can get demyelination of your pons, okay? Osmotic demyelination syndrome, okay? So for those of you who selected answer choice C, that's actually the complication if you correct hyponatremia too fast. In this case, we corrected hypernatremia too fast, okay? And hopefully you guys understand the tissue balance and how rapid correction will lead to cerebral edema. Okay, so if we go back to the other answer choices, you can see for those of you who selected C, that would be if we were correcting hyponatremia too fast. RBC lysis, that is not really what's going on here with sodium correction. Diabetes insipidus, this could be a potential cause of electrolyte abnormalities, but not a consequence. And same thing with answer choice B. Dehydration is probably maybe a cause of hypernatremia, but not a consequence of treatment. So really A and C are your two best answer choices here, and then knowing which one leads to which is important, like we talked about. So hopefully that helps explain that a little bit better, and I'll hand it back to you, Jeff.
Okay, thank you, Pars. Thanks for helping break that down. Again, even if you got C, you were on the right track, but it's important there. I'd like that nothing that subtle little rhyme from high to low. Your brains will blow, and I saw a couple of you mention that within the question box. Noting the decrease of the serum sodium level. So kudos to you for picking up on that, and kudos to the rest of you for those of you got that right, and everyone else. Again, this is renal physiology, not an easy subject. So this is a great learning opportunity for you. So we're going to go to our next question here in a minute. I do want to remind you that we will have a raffle at the end of tonight's session, and also have a very special offer to share. But I did want to just take a second. We've gotten a couple of questions about RX Coach. I did put the URL into the chat if you wanted to set up a free consult. But we've been providing RX Coach as a service for nearly 3 years now. That it'll be 3 years here coming up in 2022 in the spring. And our approach has always been, we want to learn as much about you so that we can customize a plan that will make the most sense for where you're at. So we have a 160 question assessment that'll help us diagnose your strengths and some of the areas where you've got challenges, and then we'll put together that personalized study plan. We do use a one-on-one approach, and we pair you with a highly trained RX certified tutor like Paris, like Brian, like Brenda, to help you get onto the path based on your goals. Again, you may be preparing for step one, you might be preparing for step two CK, you might be preparing for the CBSE, right? There's all kinds of, we understand that you've got different milestones, different hurdles that you're trying to get over. And our coaches are designed, that's what they're trained to do. They're trained to help ensure that you are that you're learning and you're preparing, and that you're ready once test day arrives. So on top of that, RX Coach also provides you complimentary access to our RX 360 Plus program, which includes RX Bricks, and we've consistently held a 4.9 rating, and that rating is has held for a little over a year now. So we've again, a lot of very satisfied students out there. So again, if you're ready, check us out, rx-coach.com. You can go there and set up a free consult, and we can we'll work with you to see if RX Coach is right for you. Okay, with that, we're going to go into the second half of the evening. We're going to get into question number 3. Again, we've got 4 questions tonight. We've 2 down, 2 to go. And let us see what we've got here. So with question number 3, again, the lead-in, which of the following is the most likely explanation for the limited response to potassium administration? Think about that as we read the vignette. A 45-year-old man is brought to the emergency department after losing consciousness. After he regains consciousness, he begins to experience tremors and delusions. There's no vomiting or diarrhea. Family members indicate that he has a long history of heavy alcohol use, with multiple episodes of withdrawal. His potassium level is 2.9. The ECG shows U waves. After administration of potassium intravenously, the serum potassium level rises to 3.0. So again, which of the following is the most likely explanation for the limited response to potassium administration? And with that, I will turn it over to Paris.
Thank you, Jeff. So once again, we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in. And so once again, starting off with demographics. So this is a 45-year-old male. He was brought in because he lost consciousness, okay? So you want to remember that very first presenting sign and symptom, they lost consciousness, okay? They tell us a little bit more about what happens after he regains consciousness. They give us some other medical history, some social history, and then some important lab findings. And then again, with this question, they give us another clue about after they give him a treatment, something happens to his lab levels, okay? So another added clue there. So you definitely want to make note of that. You want to try to understand what's going on and pick up on that very important clue. So then they're asking for the most likely explanation for the limited response to potassium administration. So even after they gave potassium, and not just potassium, but they gave it IV, not by mouth, but IV, the potassium still only went up from 2.9 to 3. Okay, so why is that? So what's the most likely explanation? So I think we maybe have a 1 or 2 step question. This is kind of a tougher one. I would say we know the potassium isn't rising, and we've just got to figure out, based on what's in the question, why that could be. So maybe a 1-step question. There could be another added step based on the answer choices, but could just maybe be a 1-step question. Okay. So let's take a look. Let's take a look at those answer choices, and let's see what we're working with. Once again, we'll start at the bottom, work our way up to the top. Answer choice E, volume depletion. D, metabolic acidosis. C, hypomagnesemia. B, hypocalcemia. And A, chronic kidney disease. So once again, we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Okay, great. Thank you, Paris. Again, the poll has been launched. Please go in and make your selection. Again, we had been watching those the serum levels here tonight, and had a potassium related question there earlier. So some of these things are kind of coming together. Another patient is losing consciousness. So let's see what you guys come up with. Right now, about half of you have voted. Again, when you're taking step 1, you want to make sure that you leave no question unanswered, because you're never penalized for incorrect responses. Okay, let's see. Almost over 2/3 of you have voted, so I'm going to give you a couple more seconds, and now I'm going to get ready to close the poll. Okay, closing it now. And I'm going to share the results. So you'll see that, again, we've got a clear favorite. Almost half of you selected answer choice C, hypomagnesemia. And then some scattered votes for metabolic acidosis and chronic kidney disease and volume depletion. Okay, so we're going to hide the results and reveal the answer. And the answer is answer choice C, hypomagnesemia. Good job, everybody. That's a lot to again, a lot to parse within that question. So for those of you who didn't get it right, that's okay. Paris is going to be here to help break it down for you. Paris?
Thank you, Jeff. Yep, definitely a good question. Nice job, guys, on picking up what's going on here. Okay, so this patient has hypokalemia that is unresponsive to supplementation. Okay, especially IV supplementation. Okay, now in the setting of heavy alcohol use, the most likely reason is hypomagnesemia. So heavy alcohol users often have a low magnesium, either because it's not in their diet, or they've got renal damage from the chronic alcohol use that causes renal tubular dysfunction, and you can't get reabsorption of that magnesium. So you're excreting out too much magnesium. So either it's poor diet intake, or it's renal dysfunction from chronic alcohol use that leads to low magnesium. Okay, and that also can cause renal potassium to then get wasted as well, because that promotes secretion of potassium and decreased reabsorption of potassium in your nephron. Okay, so in order for this patient's hypokalemia to be corrected, you first need to correct his hypomagnesemia. Okay, so let's take a look at the next slide. You can see here that some of the effects of having a low serum concentration of magnesium is hypokalemia, and also hypocalcemia as well. Okay, now this is a common thing that you definitely want to keep in mind. For a lot of you guys, when you're doing if you're doing a residency in a medicine type setting, or even if you're doing your intern year, the nurse is going to call you and they're going to say, hey, this patient's potassium is 3. What do you want to do? And you say, all right, let's give them some potassium supplementation. You give them potassium supplementation. You check their lab work again in a few hours. Nurse calls you back and they say, hey, potassium still isn't going up. And you're like, all right, let's give them some more. And then you can potentially keep doing that. But if you didn't remember that alcohol use and other things that can also cause low magnesium, you may not check that. But if you can astutely remember that low magnesium can lead to persistent refractory hypokalemia, you may then be like, actually, let's check a mag level. Let's see if that's low. And if it's low, then you can supplement that, and then you can fix that hypokalemia. So all of these things are not only important for boards, but you will realize, especially with these electrolyte disturbances, very important for when you're actually practicing medicine in a hospital setting as well. Okay, so definitely keep that in mind, that there is a future use for these topics as well. And then also we'll go over those other answer choices really quickly as well. So volume depletion, that would be associated with hypokalemia, but that should, even volume depletion wouldn't be a reason why potassium wouldn't improve after giving supplementation. Okay, metabolic acidosis, that would actually cause hyperkalemia. That causes protons to go into the cell in exchange for potassium to come out of the cell, so that would actually cause more hyperkalemia. Hypocalcemia, hypercalcemia could cause electrolyte changes that would make patients more refractory to potassium, not hypocalcemia. And then lastly, chronic kidney disease. This would, if anything, cause hyperkalemia rather than hypokalemia, because you're not excreting as much potassium. Okay, so nice job with this question. We'll move on to the last question of the night.
Excellent. Thank you, Paris. And yeah, again, good job, everybody. And a nice reminder from Paris that with these tricky questions, there are some valuable gems and things that you will be using once you are out there on the floor. So again, this is not just purely theoretical, right? So let us, we're going to go to our last question of the night. Again, we're going to have a raffle here after this question. You do need to be here in order to win. So make sure you stick around. So let us pull our final question of the night. Let's see what we can do to finish strong. The lead-in for question number 4 is, which of the following best pairs the patient's estimated free water clearance with the most likely diagnosis? Do your best to take that one in, and let us go and read the vignette. A 44-year-old woman is brought to the hospital by ambulance after having a seizure at home. She appears disoriented. Her vital signs are within normal limits. A urine toxicology screen and finger stick glucose are normal. Laboratory analysis shows serum osmolarity of 255 and urine osmolarity of 95, with a urine volume estimated at 4 liters over 24 hours. So again, which of the following best pairs the patient's estimated free water clearance with the most likely diagnosis? A lot to break down here, so I'll pass it over to Paris to do that.
Thank you, Jeff. And so once again, we're going to show you what we think are the important clues in this vignette and the lead-in. And this is our 4th time doing this, so hopefully you guys are picking up, on what we think are important clues in that vignette and lead-in. So when you guys at home are going through questions and dissecting them, you guys are also able to pick up on what are the important clues that you should be catching. Okay. So once again, we're given demographics and a little bit of a shorter question. We're given some information. She had a seizure, she's disoriented, but really the crux of this question is in that laboratory analysis, right? So they're giving us some serum and urine osmolarity values and urine volume as well. So that's kind of the crux of this question. So then they're asking us, what best pairs the patient's estimated free water clearance? What would you pair that with the most likely diagnosis? So I think we've got a couple steps here. I think one, obviously, we've got to figure out what the estimated free water clearance would be for this patient, and then two, use that as well as the other clues to come up with a diagnosis, a most likely diagnosis. And then we've got to look at those answer choices and make sure they pair up nicely. So I think we've got two steps here. So let's go ahead, let's take a look at those answer choices one more time. Once again, I'm going to start at the bottom and work my way up to the top. Answer choice E, positive, primary polydipsia. And once again, that is the first component. So the first half of that answer choice is the estimated free water clearance, and the second part of that answer choice is the most likely diagnosis. Answer choice D, positive, diabetes insipidus. C, negative, ADH secretion by lung cancer. B, negative, volume depletion. And A, negative, thiazide-associated hyponatremia. So we'll give you guys a second to maybe do the calculation if you need, or at least get those numbers down so you can start plugging and chugging some numbers. And then we will go ahead and we will open up the answer choices in a couple seconds and let you guys select what you think is the best answer.
Yeah, very good. Yeah, we'll keep this up just so you can make the connection, figure out which one you believe best pairs the free water clearance with most likely diagnosis. And let's go ahead and launch the poll. Okay. Again, a lot of data to crunch here, and making these connections. Need to be able to do this pretty quickly on test day, right? You got to think about this. Hey, how do I break down this kind of question and make it towards the right answer in like 90 seconds? So there's definitely a knowledge component here, but then over time you're going to have to figure out ways to break it down quickly and get to the right answer. So it's a good one to close our session with tonight. Let's see, almost 2/3 of you have voted. I'm going to keep this open here for just a few more seconds. I'd love to see as many of you make your selection here before we close the poll. And right now, it's shaping up to be a bit of a two-horse race. So let's see what you guys come up with. Okay. We've got 3/4 of you have voted, so I'm going to go ahead and close that poll. And we'll share the results. And it looks like the top vote getter was answer choice D, which was positive with diabetes insipidus. But answer choice E, pretty close, right on its heels there with 31%. So we're going to go ahead and hide those results. And let's go ahead and share the answer. And the answer is E, positive primary polydipsia. So those of you who got that one right, congratulations. And for the rest of you, let's tune in and hear Paris kind of drop some knowledge on us. Paris?
Yeah, absolutely, Jeff. So let's take a look at what's going on. So first, like we said, we need to calculate that patient's free water clearance. And you can see there, that's the equation to do so, okay? So if you calculate out your free water clearance, you plug and chug those numbers, you get a positive free water clearance. Okay, so what that means is whether if it's positive or negative. Positive means you are excreting more fluid. Okay, negative means you have a net water retention. Okay, so this patient has a low serum osmolarity, 255. That's pretty low. The urine osmolarity is also low. Okay, so that suggests that this patient is taking in excess water. Okay, and that's called primary polydipsia. Okay, that would also probably lead to low sodium if you're drinking a lot of water, and that's probably maybe why she had a seizure. Okay, so with primary polydipsia, you're drinking a lot of fluid, and that can lead to a dilute urine. Okay, so if we take a look at the next slide, what we'll see here are some of the common causes of polydipsia and diabetes insipidus. So with primary polydipsia or diabetes insipidus, you get production of large amounts of dilute urine, okay? Urine osmolality less than 300. So in this patient, you would then want to look at serum osmolality. In our patient's serum osmolality was low. So that actually points more towards primary polydipsia rather than diabetes insipidus. Okay. The treatment for this would be water restriction. Some of the causes of primary polydipsia, psychiatric illness causing someone to drink a lot, or if there's a hypothalamic lesion as well. Okay. So if we go back to our question, once we calculated that this patient had a positive free water clearance, we would then look at answer choice D and E, and we would say, well, this can't be diabetes insipidus because that serum osmolarity is too low. That would be high in DI. So this has to be answer choice E, which makes sense. Now, the other answer choices would all be incorrect, primarily because of the free water clearance is positive and not negative, so we can automatically rule out A, B, and C. Okay, so it's important to be able to calculate free water clearance and know that equation so you can know whether it's positive or negative, and then from there go down your additional steps in your respective algorithms. So great job with today's questions. Definitely some very important renal topics, some tough questions as well. I'll pass it back to you, Jeff.
Excellent. Thank you, Paris. Yeah, good job, everybody. This is a good session for you. These are challenging questions. Renal physiology is not an easy area. We've got all of the question IDs, so feel free to write these down or screenshot them. And then what you can do is you can actually just plug the IDs into the search field in Rx search. And you could go even deeper. You could review all of the explanations as well as the related pages in first aid or the explainer videos in Rx or Express videos or the bricks. So again, go ahead and take these down.